So much for being here, and please introduce yourself in the chat. We always love to hear who is attending and where you're from, what brought you to the forum today. So as we're waiting for others to join, please feel free to introduce yourself and we'll get started in just a couple minutes. I see some familiar names and faces. Thanks for joining us again. All right, we have someone on from Guam. Welcome. I don't think we've had someone from Guam before, so welcome. Someone from Mississippi, Carlsbad, California, San Diego, New York. Wonderful. Thanks so much for joining, everyone. We'll get started in just a minute. Texas, great representation across the country. Wonderful. All right, well, it's a couple minutes after, so let's go ahead and get started. Welcome everyone to our Wisdom Community Forum. We've usually have these on the last Monday of every month, but because of Memorial Day, we shifted this a week early. So thanks everyone for joining and being flexible. If you haven't yet, please introduce yourself in the chat. We'd love to see who's here and what brought you to the forum, where you're zooming in from. And just a format and reminder for today's session. So we do want to hear from you. We want to hear your questions. We want to hear what you want to hear more of. So please send your questions in the chat, or you can raise your hand or speak up during the discussion. But we do ask, if you aren't speaking, if you could please mute yourself, then we can hear the speaker clearly. We are recording the meeting, and this is so that we can share it with people who were not able to join live, and so they can listen to it later on. And then a short post-meeting survey will be sent at the end to get your feedback and to hear what topics you might be interested in next. So thank you for being here. We always start with our mission, which is really moving together toward equity and better outcomes in breast cancer for everyone. So we've been holding these forums for the past 2.5, 3 years, if not more, really trying to talk about different areas of breast health, breast cancer research, and women's health in general, to be able to provide information, but also hear about questions and topics that are of interest to you. So we've got a whole bunch of recorded sessions that you're welcome to listen to and to join in. And today we have Dr. Lisa Madlensky, who's joining us to talk about personalized risk assessment and making meaning out of all of the information that's out there, all the different risk models that are out there, and really trying to understand what these mean and how we can really best utilize them. Before we jump into that, a couple of announcements. There's a couple conferences that we always like to promote. One is for our partners at Facing Our Risk of Cancer Empowered. There's a conference in Philadelphia that is coming up in June. I'm happy to share links for this, but it's for individuals who have hereditary cancer risk, and really trying to provide information and guidance and resources. Also, a new conference that's been developed this year is called Rise Up, Revolutionizing Investigations to Step Up Prevention for Breast Cancer. And it is the first part of November 1st through 3rd in San Francisco. There's a website that we can share as well. Registration is almost open. They're trying to get the website up and running, and would welcome anyone to attend this conference as well. So with that, I will introduce Lisa. I've had the pleasure of working with Lisa for the last, 8, 10, I don't know how long years. And every time I hear her speak, I'm always in awe of just how clearly she can explain things and really provide great context to the information that can sometimes be pretty complicated. So happy to have Lisa here today. And again, please feel free to answer or ask questions, and we'll be sure to answer those throughout the course of the discussion or at the end.
Thank you,
Awesome.
Allison.
Yeah.
Can you hear me okay?
Yes.
Okay, excellent. Got a little some audio visual challenges today, but we moved through this. So this talk kind of came out of a couple of different things that happened simultaneously. But I just really love having dialogue with wisdom participants, people who are involved in recruiting people to wisdom and getting them involved, healthcare providers, everybody else, because this is really the front lines and the cutting edge of breast cancer risk assessment. And what I'm going to go over with you today, I'm a very informal speaker, so please, and because I'm working on my phone now and not on my computer screen, I'm not opening the chat, but I hope Allison and Steph and others can just let me know if there are questions that pop up. But I gave this talk a couple weeks ago at a meeting in Chicago for mostly PAs, NPs, physicians, oncologists, genetic counselors who are all involved in the front lines. If a patient comes in and says, hey, I want to know what my risk of breast cancer is, and should I be getting mammograms? Should I be getting something else? What should I be doing? And we always talk about part of the reason for wisdom existing in the first place is because there's so much confusion out there about what to do for women in the community. There's also a tremendous amount of confusion on the healthcare provider side of like, what model do I use? What calculator do I use? There's all these new things. How do I incorporate this into my practice? So I've taken some of the elements of that and put it into this. Some of the things may look a little complicated, but my job is really to walk through this and if nothing else, spur some questions and comments about, how does the sausage get made is really what a lot of this boils down to. So if you can go to the next slide, please. So part of what happened right before I was about to give this talk in Chicago is the People magazine that very week. This was the cover story. Olivia Munn had been diagnosed with breast cancer. She was going public with her story, but her OBGYN, who's kind of like an OBGYN for celebrities and has her own like social media presence and everything, really was emphasizing that the thing that saved her life was her OBGYN's decision to calculate her lifetime cancer risk as saving her life. And I want to make it really clear, every person's cancer story is their own unique story. And a lot of times when we read celebrity stories in the media, especially as a healthcare provider, we might have an initial reaction like, well, wait a minute, how did that work? And what calculator did you use? And how did this all suss out? And the truth is, unless we have access to those medical records, we really don't know what went on or how it went on. And so at the end of the day, this is the public story that's being told. And so this was very timely because we kind of expected that there was going to be a bump, just like what happened with Angelina Jolie when she went public with her BRCA testing and her risk-reducing mastectomies. There was what's now called the Angelina bump in cancer genetics clinics all across the country. So we kind of wondered, is there going to be like an Olivia risk assessment bump? But then what happened a couple days later, or a couple weeks later, I should say, is that the new guidelines came out for breast cancer screening, and that kind of took up all the oxygen in this discussion. But what was interesting was there were a few articles in the lay press about the Olivia Munn story. And if you can go to the next slide. There were a few articles that kind of said, okay, whoa, we see the Olivia Munn story out there. And what we want people to know is it's not like there's a magic calculator. You go online and you enter a few data points and it spits out a risk at you. And you're like, okay, that's my risk. This is what I do. There's a lot of caveats and a lot of kind of wiggle room in how the sausage gets made, how these risk assessment models work. So a couple of articles came out that kind of said, okay, yes, there's risk models and there's risk assessment, but like, please proceed with caution because there's so much nuance. And again, going back to what is the wisdom study all about, it's all about personalization and how do these risk assessments change over time. And that's something that kind of got lost in a lot of these articles that were out in the lay press. Next slide, please. So just to give you an example, these are what you will see if you run 3 different risk models. This is my own risk modeling. I always like to use myself as an example whenever I can. I will also say, full disclosure, I'm a wisdom investigator. I'm also a wisdom participant, proud participant. But so if I go into like the apps and the calculators and the things that I have available to me as someone who does breast cancer risk assessment every day, one of the things that always jumps out at me and really honestly is a source of frustration, these numbers look really accurate at first glance, right? Like there's decimal places there. Like the one in the maroon color over on the right side says the 5-year risk is 2.65%. And that sounds incredibly precise and incredibly accurate. The other thing you'll notice is that some of the calculators give a 5-year risk or a 10-year risk or a lifetime risk. So depending on what you put in and which calculator is being used, you're going to get different output. The other thing you'll see is that the numbers are not the same. You'd think, well, if I'm giving calculators the same information, why aren't they giving me the same number when I put it out? If I use the calculator on my phone to, figure out, okay, if I'm buying something at the grocery store, is it a better deal to buy a dozen of them or 2 dozen of them? And I should get the same number every single time. You do this in breast cancer risk calculators, and you're going to get different numbers every time. And you're going to get different levels of time frame for this. And this is a really, really important point, because what might happen as a result of the kind of push to do these risk calculators on everyone in the population at the age of 25 now, is some of them are going to get a lifetime risk. If you think about how many years is the lifetime of a 25-year-old, right? Let's say we project she's going to live out till age 90. That's a huge amount of time. And everything we know about breast cancer now, we're just going to be embarrassed at how crude and uninformed it was by the time that person gets to be even age 50. Like 25 years from now, you'll probably go in and put your thumb and get a little blood drop or a retina scan or walk through an MRI tunnel, and everything will be known about our bodies, right? Like, I don't know what's going to happen, but I can promise you it's going to be way more advanced and accurate than what we have now. So right now, this is what we have. We've got these risk calculators. And so the whole idea of giving lifetime risk to really young people doesn't make a whole lot of sense, because it's going to change over time. The idea of short-term risk is appealing because it means we can keep incorporating your information over and over again as it updates, right? You turn a year older every year. Your family history changes over every year. Your reproductive factors, particularly for young women. So if we ask women who are 25, what was the age of your first birth? Well, many or most of those women have not yet had their first pregnancy. So that ends up being a missing data point for them. So my point here is just to say, these are not perfect tools, but they're a starting point. And, these are the tools that wisdom is kind of really trying to refine and understand and work with a little bit better. Next slide, please. So as cancer genetics professionals, if you go to a clinic and say, I'm concerned about my family history, or I found out I have dense breast tissue, or, any number of things, I'd like to get a risk assessment. We start with baseline risk, and your baseline risk is really saying, look, what is your ancestral background? What country do you live in? And how old are you? Those are really the core things that identify what is your baseline risk. So when you hear things on the news like 1 in 8 women get breast cancer, or every woman has a 12% chance of getting breast cancer, that's sort of a really crude way to say, well, this is the baseline risk. Then we want to find, well, what are the things that might increase that baseline risk, and what are the things that might decrease that baseline risk? And we know that some of those things weigh very heavily. Other things might not move the needle by very much at all, and they're not going to make a big change. But then where things get complicated is in these models or calculators. It's really complicated statistical modeling that puts all of these things together, weighs some things heavily, weighs some things, less heavily. And then at the end, it should give you an output that is supposed to be a better personalized estimate of your risk. And what that is meant to say is not to be predictive, right? At the end of the day, we can give numbers and say, well, there's an X% chance of breast cancer for any one individual. Really, what will happen is either that person will live out their life and they'll never get breast cancer. That's going to be the majority of people. Or they'll be living out their life and at some point they will get a breast cancer. So there's no crystal ball here that says, oh, these are the people that will and these are the people that won't. The reason that these breast cancer risk assessment models were kind of invented in the first place was because years and years ago, there were new medications that were looking really promising for reducing the risk of developing breast cancer. But when you do a study, and one of the outcomes of that study is to count up, well, how many people who got the drug ended up getting breast cancer, and how many people who got placebo ended up getting breast cancer. If you do the study on really young women and they're all low risk, you're probably not going to end up being able to count enough breast cancers to do a fair comparison of the drug group and the placebo group. The way to get the answer faster is you find people who are at higher risk and are more likely to develop breast cancer, and that will help you get the answer faster because more breast cancers are going to occur in the high risk group. So just to step back for a minute, this is a really important point. So if a risk model spits out something and says, you have a 15% chance of getting breast cancer in your lifetime, or, as we saw with the output, a 15.27% chance, which sounds really accurate. That doesn't mean you personally have that level of risk. What it means is if I take 100 people who are just like you, same age, same background, same risk factors, same protective factors, and I lock you in a room and I watch what happens to you for the rest of your lives, give or take 12%, maybe 10%, maybe 15%, or sorry, I used the example of 15% risk. So maybe somewhere between 10% and 20%. Somewhere between 10 and 20 women will probably develop breast cancer in that group. That's what that risk output really means, right? So it's actually putting you in a group that says, well, here's how many people in this group we expect will develop breast cancer, but there's wiggle room there. So this is one thing that's kind of, I don't want to use the word deceptive, but when we shifted from using risk models for clinical trial purposes and instead started using them on an individual level to tell you what is your personal level of risk and what should you be doing about it, that's where things get a little complicated because we always want to try to simplify things, but sometimes stuff like this is really extraordinarily complicated. And what this all comes down to, we can calculate stuff in these calculators and risk models all day long. But at the end of the day, what we want to figure out is, well, where's the point where the calculated risk tells us, okay, we need to change things here. Either your risk is high enough that we've calculated that we need to do more than what the average person does, or your risk is so low based on everything we've looked at that maybe you don't need to do as much screening. So that's really the goal, is to try to find where are those cut points where it makes sense to do the typical thing, do more than the typical thing, or maybe do less than the typical thing. All right, next slide, please. So this is an area that I've been interested in for a really, really long time. And the point here is these are all published medical manuscripts in journals. They're all the results of studies that tried to answer the question, hey, when people fill in those surveys and we ask them all of these questions, is it accurate if we ask people to tell us about their family history and then we actually go and track down the medical records of those family members? Did we get accurate information? Can people self-report their own cancers accurately? Can people self-report, if we ask them on a family history questionnaire, did you ever have a relative that had bilateral breast cancer? And people say, yes, my aunt or my grandmother had bilateral breast cancer. It turns out a lot of these data points are really not accurate at all. And this kind of makes sense when you think about it. Some families are really open about their medical histories. Others are a little more private about their medical histories. A lot of times there might be literacy or language challenges where people are thinking they're hearing information from a healthcare provider about their own diagnosis. So one thing, in that bottom left study that says accuracy of self-reported breast cancer, it did find that women who have lower literacy, maybe the difference between DCIS and invasive breast cancer or some benign things like atypia, they're using the language and the medical terminology. A lot of women weren't sure, like, do I have breast cancer? Don't I have breast cancer? This is still an issue now. But the point here is that when you're calculating risk using one of these models, we're relying on people to fill in their surveys. And with family history, with all the other things, we assume it's accurate. One of the really interesting ones is in every one of these models, pretty much it will ask you, do you remember how old you were when you had your first period? And if you do a follow-up questionnaire, question to that, which is, well, how confident are you or how sure are you? People either know exactly, like I remember it was the week before my 11th birthday and I was in this change room and I freaked out, like they remember a life event, or they're like, gosh, I don't know, that was like 40 years ago. I guess I was around 12. And maybe it was a little higher, maybe it was a little lower. So some things, depending on how, impactful that life event was, can be very accurate. Other times they're not. One thing that is really not accurate, we ask people, do you have any family members who had ovarian cancer? And it turns out that's only accurate about half the time. And it turns out anytime you ask about relatives, cancers that are in the pelvis or the abdomen, sometimes it's generational, right? People didn't want to talk about like anything going on down there. Other times it might be that those are often more advanced cancers than breast cancers can typically be. And so you end up with, well, maybe it started in one part in the abdomen, but then it spread to another part. But what they heard was that someone had bowel surgery, but really it was an ovarian cancer, but they only remember the bowel part of it. So the point here is just that when we give people the output from these risk calculations, there has to be wiggle room in there that accepts that not everything is necessarily 100% accurate that's going in. All right, next slide, please. Now, this is very technical, but the point that I want to make here is that this was a study that was done by our colleagues at UCLA. And they took 3 different risk calculators that are widely available. These are the same 3 that I had on that first slide. And they calculated the risks for several thousand women. And they wanted to really look at like how often do these agree, right? If I put my information into 3 different models, do I get the same result from all 3 or do I get different? And what you'll see at the top of those 3 little kind of 2x2 boxes where it says discordance. So the first one says 23.6% discordance, then 21% discordance, and 26% discordance. That's actually surprisingly consistent between all 3. But what it means is if the first model tells you you made the high risk cutoff, about 3/4 of the time, the other models will agree with that. But about 1/4 of the time, the other models are not going to agree with that. And so this is a challenge, right? Like, which is the best model to use or which is the most accurate model to use? And then this points to another issue. Next slide. which is the idea that where do we set the cutoff to call someone high risk or elevated risk? And the stakes here are that if we set a lower cutoff, we're going to find more people who will ultimately develop cancer, but we're going to end up doing a lot of extra medical high risk stuff to people who will not, right? So if you set a lower threshold, you're going to do more screening to more people, you're going to find more cancer, but you're also going to do more extra stuff that was never needed. If you set the cut point higher, we're going to screen fewer people and we're going to miss more cancers, but we're going to avoid a lot of the extra medical stuff being done to people that, we didn't end up needing to do. And the issue here is that we cannot predict who will get breast cancer and who will not. What we can do is say, okay, you're in a group of people where we predict more of you will end up with breast cancer, or we can predict you're in a group of people where fewer of you will get breast cancer. But in the group, we can't tell which are the people who will and which are the people who won't. So the idea here, and this is part of the principle of the wisdom study, is this idea of enrichment, right? Can we find groups of people that are enriched? They have more people at higher risk. Those are the ones we want to make sure they're getting high risk screening. And who are the groups of people that have a lower risk, where we can feel more comfortable saying, high risk screening is not something that's recommended. And, kind of what are the guardrails of screening that makes sense? What age should you start? What age should you stop? Should you go every year or every other year? So those are the things that we're trying to answer. And that's where the math of these risk models comes into play. Next slide, please. So again, the idea here of like, now that you have this understanding of how the sausage gets made, looking at these numbers and making decisions based on them, one of the things that happens is there's medical societies out there that make guidelines and say, well, how old should you be when you start screening or you stop screening, and how often should you get it, and which are the cut points we should use to determine who's at high risk or who's not at high risk. And this is where there's also a little bit of confusion. So let's go to the next slide. So a new component, and this is part of the wisdom study, is this idea of a polygenic risk score. So most of you know that in the wisdom study, the genetic testing is the traditional genetic testing. So it includes testing for the BRCA genes, it includes testing for a handful of other breast cancer genes. And in the next iteration of wisdom, it's actually going to be a larger test of 29 genes, breast cancer genes, but also some other cancer genes as well. So that's sort of the traditional genetic testing. The other thing we do is called a polygenic risk score. And this is something that now gets added into the risk models. And the idea is it's another data point that tells us something about you at a personal level to help us kind of calculate and figure out, well, which group should you be in? So an analogy I use for this, I call it like nature's poker hand. So if you imagine that you are getting dealt from a random set of card decks, like 300 cards, and everyone out of millions of people most people are going to have like a mix of high cards and low cards, right? But you're going to find people in a large population that some people got dealt like a whole pile of high cards and some people got dealt a whole pile of low cards. And what deck you use may depend on your ancestry, because we're talking about genetic risk factors. So these cards are ultimately coming from your ancestors, and some cards might count more than others. But the thing with a polygenic risk score is that each of these individual cards on their own doesn't really change your risk in a meaningful way. Otherwise, it would be on the test like with the BRCA genes and those other things, where a single genetic change has a really strong impact on your risk. Here, we're talking about a single card that really doesn't change anything. But if you add them all up, then we find the people who have those really rare, kind of outlier hands. They've been dealt a really high hand or they've been dealt a really low hand. And those are the ones where it may actually change what recommendations are made. And what's interesting here is that there's a lot of, this is one of the hottest topics in research right now, is what's the best way to add these up? Which are the decks that are being dealt out in the populations? How do we count these cards as accurately as possible? And we know that once you're dealt your cards, right, the moment you're conceived, your cards are set. You cannot change them. But the way we add them up and the way we calculate the risk can change over time as we learn more about how these smaller genetic changes actually impact risk. So even though some things can't change, other things like the way we do the calculations can definitely change. Next slide, please. So this is just to show you an example of how the polygenic risk score can impact breast cancer risk. So again, if you get tested and you find out you have a BRCA gene mutation, or you have a mutation in one of the other breast cancer genes, or that tall pink peak over on the far left that says non-carriers, that's most people in the population who are not carrying a BRCA or other gene. The average risk, so we started with these average risks and say, well, you know, the average person has a risk of, say, 12%. But when we add that polygenic risk score, we add your deck of cards in there, now it spreads out. And so some people are down like at a really, really low predicted risk. And other people who got dealt that really high hand, their risk is creeping out towards that 40% lifetime risk, right? And we can also do this for people who carry the gene mutations. This is a little newer and really a little bit more experimental right now. But in that non-carriers group out on the left, which is most people, this is a really exciting way to figure out, okay, there are people who maybe don't have family history, don't have other risk factors. If we did that traditional risk modeling and calculating, they wouldn't be elevated risk. But now we've done this kind of fancy polygenic risk score for them. And we find there are a small percentage of people who are out there with a really high risk. And there are people out there who we've looked everywhere for risk factors and we can't find any, including their polygenic risk. They're on the other side of that curve, the other side of that distribution. So this is how this is kind of sussing out. And this is really one of the innovative things about wisdom. Next slide, please. So in terms of practical use, you know, one of the things I think it's important to know is that even though a lot of mammography clinics and a lot of healthcare clinics have started automatically generating these calculators and these outputs when you just go in for your routine screening, and a lot of times there's this magic number of 20%. If it gives you a number of 20% or higher, you should get an MRI. And the truth is, if you go back and you read the guidelines where this came from, the language is a little bit softer, right? So the two guidelines that are used across the country in a variety of settings, there's NCCN guidelines, which are really more designed for people who have a cancer diagnosis, but they do have guidelines for screening and prevention as well. And the American Cancer Society, that's the one that everybody quotes and says, oh, 20%, get MRI. No discussion. Both of those guidelines actually say pretty clearly, like, whoa, the calculators are a tool for shared decision making. They are not a diagnostic test. They are not fact. You know, you can go in one day and calculate it and then say, oh yeah, was my grandma 60 or 65 when she had her breast cancer? I'm not sure. I'm going to put 65. It will change the output, right? So it's acknowledging that there's wiggle room here and that these calculators are not the be all end all, but they are a starting point. So this is also in the context of baseline risk for breast cancer in the US compared to a lot of other cancers is relatively high. Most of it is not genetic. And that points to the idea that there must be other non-genetic factors at play. There's a lot of really interesting research going on now in terms of environmental exposures, lifetime exposures, zip codes that you grew up in, all of these more environmental and external factors we're learning a lot about. And we want to end up incorporating that into the calculation as well. But if you start off with a relatively high number as your starting point, and you add a couple of risk factors and you multiply them, it doesn't take that much to get to that 20% for a lot of people. So prediction at the individual level is not great. These models turn out to be pretty accurate for predicting how many people in a group are going to get cancer. But again, it won't tell you which people in the group are the ones that will and which people are the ones that won't. Next slide, please. So the current guideline from NCCN, even though there are some polygenic risk scores that are out there by some commercial laboratories, the NCCN guidelines say there's validation studies underway. Wisdom is one of those, including those with diverse populations. And at the present time, polygenic risk score is best utilized in the setting of a clinical trial. So we welcome people into Wisdom to be part of this, right? To get that polygenic risk score incorporated into their risk assessment and really have a better understanding of, okay, did this move my risk up? Did it move my risk down? For most people, you're going to get that deck that's mixed high cards and low cards, and it's not going to move things very much. But it will allow us to find the people on the ends of those curves where it's really high or really low. Next slide, please. And yeah, here's the list of studies I could find that are currently testing polygenic risk and risk models. I could only find one. I don't know if anybody knows of any others, but that's the one that I could find is the Wisdom study. So I think that's it for my slides, unless Allison, I don't know if you guys added anything else that you wanted to add to that, but I'd love to open it up for discussion and answer any questions that any of the folks on the call have.
Great. Thank you so much, Lisa. That was super interesting.
I love the poker analogy.
Yeah. There are a couple questions in the chat. One, they both are similar. If someone is over 65 and Medicare doesn't require a pap smear anymore, and then therefore you lose your OB/GYN, how do we go and get a risk assessment?
So it honestly, this is a tricky question because it really depends on the health system you're in. Some health systems will, whether you're Medicare or whatever your insurance is, they will happily refer you to your primary care or to an OB/GYN. Other, component to Wisdom. So that's a hard one to answer just because it is so dependent on your location and your insurance plan and the system that you're in. I'm Canadian, so I always kind of avoid these questions, honestly. Now I've lived here 20 years, so that I'm kind of copping out. I admit that. But the truth is, like, I'll see 5 people in a week, and some of them, they're, oh, well, I'm in the VA and they told me to go to this place, or I'm with Kaiser, but they said they're backed up. So yeah, the oot and a boot, there it is. So it's a tough one to answer, honestly. And I think the best starting point is always going to be your primary care physician. Say, hey, if this is something I'm interested in and you think it's important for me to do, can you do this? Can you help me through it? Or can you refer me to somebody who can?
Yeah. And if you are a woman between the ages of 30 and 74 in the US, you can get your risk assessment through Wisdom, which includes the polygenic risk with our genetic test. And there was a second question about, do you have a polygenic risk score for all women? So in Wisdom, if you're in the personalized arm and you complete the genetic testing, then yes, we do have a polygenic risk score for everyone in the study. And that is something that's unique to the Wisdom study, as Lisa mentioned.
Yeah, just a little bit of background on that too. There used to be a few more polygenic risk scores that were available through a variety of commercial companies. And one in particular, it's still kind of shocking that this was out there, but it was, and it's since been changed. But because these decks of cards come from our ancestors, and this is true of all genetic research, it's improving, but there's still a long way to go. But most of the genetic changes in the databases were really primarily coming from women with European ancestry. These are not terribly diverse databases. And I used to have a slide. I should have kept this slide, but it actually said in the fine print on the requisition form. So if I was ordering a polygenic risk score for a patient, and on the bottom of the requisition, it had a little disclaimer and it said, no, this test is only for women of European ancestry. Like, that was the reality of this company offering this test. One of the companies that had a similar test pulled theirs off the market, and they said, until we can do it for everybody, we're not going to do it. Like, this isn't right. The other company, kind of odd timing, like a few months or maybe even a year later, said, oh, we validated it for everyone now. So we've removed the disclaimer and everybody can get it. But because they're a private company, they don't have to publish their data or get it peer reviewed or have it validated by any external, group. So one of the really interesting things about the wisdom study and the way we're approaching this, there are some ancestry specific polygenic risk scores. So if somebody indicates that they have African ancestry or Asian ancestry or Hispanic ancestry, the polygenic risk score is calculated according to the deck cards that your ancestors started out with. But where we're moving is actually a little more clever than that. And it's saying, well, instead of how do you self-identify? And what if you're mixed? Like, what if you're 30% something, 30% something else, and 30% something else? Which polygenic risk score is the right one? So there's researchers at UCSF that are developing really clever polygenic risk calculators that look at, once we have that DNA, you know how you can do like 23andMe and Ancestry and learn your ancestry? It actually uses your genetic data and then understands, oh, this is your genetic background. These are the decks of cards that were available from your ancestors. That's what we're going to use to calculate it. So it's kind of really shifting the way this is done. And it's really, really innovative. It's also, I will admit this, sometimes we have folks who join Wisdom and one year they're in the average risk category. And then the next year they jump up a little bit and they're like, well, now you're in the higher risk category. And then the following year, it's like, well, no, now you're back down. And that, we understand that can be really frustrating and confusing. But part of it is because when we update the models, a few people each time who are sitting really close to those cut points are going to move up or down, depending on how we recalculate things. So that was kind of a long and complicated answer, but I think the point to make is that the polygenic risk scores we're working on, the whole, like Allison said with our mission at the very beginning, is that this has to be equitable. This has to be available to every single person, right? And so the idea of saying, well, only if you fit neatly into one of these boxes can we calculate this for you is just not an option. So still a lot of work to be done, but it's moving quickly in the right direction.
Wonderful.
In Wisdom, we use it as another risk factor that goes into your risk model. So we do have people who join Wisdom, they are interested in getting this done, and for whatever reason, they just never got around to sending in their saliva sample, so we never got DNA, we were never able to calculate it. We still calculate a risk score based on all the usual things, like their family history, their reproductive factors, their breast density, all the other usual things. Once we get a polygenic risk score generated in the lab from someone, that goes into the model along with all the other things. And so the actual risk percentage that you're given, that we calculate, is based on what we call the raw score. But where we set the cut points is in some cases based on your percentile. Where are you in the distribution? I won't go into the details of that, because that literally, we have a committee that meets every 2 weeks, and the stack of documentation, Allison can speak to this. It is long and storied and incredibly complicated. But the thing I think I want to make sure people understand is It's a little bit of both. Your raw calculation goes into your score, but then where we put you in terms of which assignment you get is sometimes based on a cut point.
Yeah. And then someone asked a question about how do we make talking about PRS easier? Like 1 in 8 women is easy to say, right? How do we talk about PRS in an easier way and you know, the importance of it and or what we're trying to learn from it?
Yeah, I think, and that's something you can probably tell is near and dear to my heart because it is a complicated thing to explain. And like I've been in cancer genetics my whole life, and I'm still kind of testing out ways to explain it in a clearer way. So to me, the card deck works well in genetics because everybody, I think almost all cultures across the world have card games that they play and can understand the idea of like there's randomness into what cards you get, but it's not so random because you start with a deck. And so you're limited in what you can get by what's in that deck in the first place. So that analogy makes sense. Stepping back and kind of looking at the bigger picture of polygenic risk, there's still a lot of people who aren't really familiar. I just saw a patient this afternoon before I got on this call who came in for a breast cancer risk assessment. She was concerned because of her family history. And when I brought up, genetic testing for the BRCA genes, she was like, I've never heard of that. What is that? So, there's still a lot of people out there who are not familiar with just what we think of as traditional genetic testing. BRCA genes and now some of the other what we call panel genes that are like BRCA, but not quite as high level of risk. And the thing I want to make, if you're explaining this to potential participants or friends or colleagues, the polygenic risk is not that at all. So we're really doing 2 completely different methods of genetic testing. One is who are the people who have that single mutation that's been passed on in their family tree and may warrant being in a truly high risk group. And then there's the polygenic risk score, which we all are dealt this deck of cards, and it's really that combination of tiny, tiny changes that can add up. And most of the time, those changes are going to cancel each other out. But other times you're going to find people that got dealt, the royal flush or like all the low cards. And I think that can help, we can have like 4 sisters in the same family who all get different polygenic risk scores because their parents, even though they started with the same decks, they dealt different hands. It's the same reason why siblings don't look alike or have the same health problems or have different hair color. Those are all part of the decks. We get really focused on breast cancer in these talks, but really everything we inherit from our parents, some of it is single gene, really important high risk stuff. And most of it is human variability, which is just, that's humanity. That's what makes it interesting.
Awesome. Another question is about, feels like the news is full of stories lately of women under 45 getting breast cancer. Is there truly an increase in younger women, or is this just media? We're hearing more things in the media.
Yeah. So those studies are coming from, so across the country, there are cancer registries in certain states or certain regions. And by law, they have to count every single case of cancer that occurs in their jurisdiction. It's the short form for it is SEER, and it's called the SEER data. And it sort of is like every year the American Cancer Society puts out in April, like, here's the latest data, here are the trends, here's what we see increasing, and here's what we see decreasing. And in multiple cancer types, not just breast cancer, but in multiple cancer types, we are seeing an increase in younger people getting diagnosed. Colon cancer is actually the one that's kind of been the most shocking because the rate of increase has been quite, surprising. And there's a little bit of fear in there because it's like, well, what's happening? Like, this isn't genetic, right? This is something that's happening that has to be because of external factors, but we don't know what they are because a lot of times your cancer risk factors happened 20 or more years ago, right? By the time we measure them, we might not know what those risk factors are. So yes, the risk in younger women has gone up in the past couple of decades, but the rate of increase isn't as what I would call alarming as it is for other cancers like colon cancer. But yeah, it's not.
I would say, yeah, I would agree with
Yeah,
that.
go ahead, Laura.
The rate is, there's definitely an increase. It's not a lot, but one of the things that I think people are concerned about is, one of the links that we know is important is alcohol. And there's been we know that in Marin, when we saw these increased rates of breast cancer, one of the culprits was an increased consumption of alcohol. And the rates or the amount that people are drinking across the board is a little bit higher. So that's certainly one of the concerns, and just reminding people that trying to be being moderate in your drinking is important. Like 3 to 5 glasses a week is what we're talking about.
Yeah, yeah.
And Graham, Walter Willett, who was on the call on Friday, gave a talk in December, kind of emphasized that.
Yeah, yeah. So it's true. It's not just the media, but sometimes the headlines.
It's relatively small.
Yeah, the headlines can be a little more alarming than the actual rates.
Another question. I'm a 74-year-old Black woman. I have had 2 lumpectomies, 2007 and 2018. Is it worth my time and effort to get tested?
What was the age? 74?
74. Mm-hmm.
I mean, here's one of the questions.
Too.
Yeah, yeah.
There's lots of reasons to know, right? I mean, the thing is that increasingly we're testing new drugs, new approaches, new things. I think it's one of these things that's good for you to know, and it's good for other people in your family to know. If there's nobody in your family, of any kind that, that might mitigate that, but don't you think?
Yeah.
Lisa?
I do, and I tell folks too, I do a telehealth clinic with people out in Palm Desert, where I learned very quickly, like 70 is the new 50. People are living longer, healthier lives, and we don't want to just say, well, if you've made it to 74 and you've never had breast cancer before, your risk of developing it moving forward is probably low, but you do have risk factors, and it's going to be an individual decision, right? So we're not going to do a risk assessment in live time on the call, but I think it's worth asking if there's a lumpectomy history. Sometimes women in their 60s and 70s still have dense breast tissue, and there might be medications that are something you can consider. So it's going to be a different answer for everybody. If we have somebody who is older but has a lot of other serious medical conditions, the chance that breast cancer is going to make a big impact on their life might not be very high. And so for that individual, going through that process might not make sense. But for a pretty healthy 74-year-old, it just, like Laura said, thinking about yourself, but also your family members and what they can learn from this too.
Mm-hmm. All right, another question. What causes a risk score percentage to change from year to year? For example, 1 year, 31%, and the next year, 21% lifetime risk.
Yeah, so we see this a fair amount, and sometimes it is, this is really seeing how the sausage gets made. There was one very popular risk calculator, and it's gone through multiple versions. I think they're at version 8 or version 9 now. But version 7 was the version that when the software went out, in the background, one of the default settings was toggled on. And that toggle was something called competing mortality. And what that toggle means is that the model, the calculator, makes the assumption the only thing that can ever happen to you to end your life is breast cancer. There's no other options. Now, intuitively, you're like, well, that's obviously not true, right? So it was overestimating the risk for everyone that the clinics that got that software and didn't know to go in and toggle that off, it was systematically overestimating risk on everybody. So sometimes it's software. Sometimes it might be something like a typo, right? Like maybe you had a sister who had breast cancer at 62, but you were in a rush that day at clinic, or you didn't have your glasses and it came out as 26. So if it was entered as 26, it would really increase that risk level. If it's 62, it's not going to move it up by very much. So that's one of the important things, is a lot of clinics are starting to just do this in an automated way, and no one sits down with you and says, okay, let me confirm all the things you put in here. Other times things happen like maybe you use one calculator and it says, have you ever had a prior breast biopsy? Yes, I have. Well, what was it? And it gives you this list of like 6 really technical terms: atypia, proliferative without hyperplasia, right? And most women, they're just like, it was benign. That's all I know, is they took something, it was benign, I didn't have cancer. But there are different levels of risk with each of those benign findings. And so it might be that one year you think, oh, I think it was this one, and you click it. And then another year you think, no. I now that we have electronic medical records, I could see, and I could tell it was actually this one, and you click the other thing, and then that changes it. Your age, every year you get 1 year older, and that kind of resets the baseline as well. It shouldn't make it change by 10%. That should not happen by age. But it can make it change by a couple of, move it a tiny bit up or a tiny bit down. And we see that in wisdom. So that's one thing we want to communicate. This is dynamic and it does get recalculated. And there may be times in your life when being in one group makes sense, and then it'll change. And then we're going to shift you back to a different group. That can make it more complicated, but I think it also, at the end of the day, puts our money where our mouth is, right? Like, where are the times in your life where it makes sense to do more, and where are the times in your life where it makes sense to do a little bit less? That's what we're really trying to get at.
And then there was a question way at the beginning about methylfolate was mentioned during one of the past sessions, maybe just folate. I think that was maybe in combination, Laura, with the alcohol consumption, perhaps. Do you recall that conversation?
That was the point. If you're going to drink, make sure you are taking vitamin B12 and folate.
I'll do that.
Are there any other supplements that are useful? I think is also part of the question.
I'm going to give that to Laura. I don't think so, but.
We had a really great session too on fiber. That was with, my gosh, I'm completely
Katrine Whitson.
Katrine Whitson, yeah. So that was another great one that's in our recordings if you're interested on fiber and just the role in general with health, but also with
most
cancers.
Americans eat 10 to 15 grams of fiber a day, and the recommended amount is like 40 grams of fiber a day. So, and there's lots of good foods that are, rich in fiber, like avocados, raspberries, all the, lots of fruits are great. Chia seeds, throw chia seeds on everything.
Lisa mentioned environmental factors, and for those who didn't hear it in past sessions, we actually just received a Department of Defense grant to start looking at environmental and residential history so that we can start to build that in and understand, who's been exposed to what. Are there certain correlations that we're seeing that, we'll also be doing some DNA methylation analyses on some of the samples so we can try and see if there have been changes as well. So lots of really, I think the value of wisdom in this huge cohort that we have is that we can continue to build in new questions and learn and, really be able to try and contribute to the science together. So yeah, it's a great study. If you haven't joined, we encourage you to do so and share it with your friends and family. I see the last commenter noted that she's a participant, which is awesome, and looking into getting other family members involved as well. So yeah, we just have a minute or two left. Any final questions?
Yeah, let us know what other things you'd like us to talk about. That's always very important, and always bring up topics and issues we're happy to talk about. anything, or if we don't know something, we'll get someone who does to come talk to you guys.
So for the month of June, we are near certain that we will have one of our collaborators from Kaiser Northern California, who's a radiologist and works in the space of AI and breast cancer and imaging. So we're confirming that Dr. Arasi will be able to join, but that should be on the books for next month. If not, we're trying to slate him in the next couple of months. So yeah. So if there are any other topics you'd like to hear, there is a survey in the chat. Please complete that. Let us know how you like today's session, suggest other topics. We'll be posting this for future reference. You're welcome to listen again or share it with others who you know might be interested in this as well. So yeah, wonderful. Thank you for being here. Thank you everyone for your great
Lisa,
questions.
don't forget to send me your draft editorial. We're trying to write an opinion piece about the new screening guidelines. I would just say in passing, I think the U.S. Preventive Task Force has made a change that will have a very small impact on how effective screening is, but it will have a big increase in the personal cost to women and the overall cost of screening without making a substantial improvement and change. And I think that's what's frustrating about the guidelines. We need to do something different and better, not just keep moving things around based on data from 30 years ago. And, it's what we're trying to do and change that with wisdom.
Yeah.
So to spread the word, help us generate the data to make things better for everybody.
Yep. All right. Thank you, everyone. Thanks so much for joining. Thank you, Lisa. Have a great evening,
you.
everyone.
Bye-bye.
Bye.